Okay, endometriosis. What is endometriosis? Endometriosis is totally benign condition. It is not pre-malignant condition, okay? It is a totally benign condition of a presence and the growth of endometrial glands and tissue and stroma out of the endometrial cavity. So the endometrial glands and stroma should be in the endometrial cavity. If this endometrial glands and stroma is out of the endometrial cavity, then we have the case of endometriosis. Okay, what are the most common sites of endometriosis? First of all, ovaries. Ovaries is the most common site of endometriosis, with nearly 65% of cases with ovary endometriosis. Cul-de-sac, okay, the sac behind the uterus, is the second most common site of endometriosis in the uterosacral ligament, okay, and these two, ovaries and cul-de-sac, represents the most of the cases of site of the endometriosis, okay, but endometriosis can be found in any site of the body, okay, in the vagina, in the bladder, in the peritoneum, and in any other site of the body, okay? Let's start with the risk factors of endometriosis. What are the risk factors of endometriosis? Nulliparity. Okay, so most of the cases of endometriosis, the patient comes to you with infertility or nulliparity, okay, with no children. Caucasian also is associated with high rates of endometriosis. The third risk factor is high socio-economic class. So the woman who comes to you with endometriosis will most probably be with no children, white woman, and with high socio-economic class, okay? These are the risk factors of endometriosis. What about the pathophysiology of endometriosis? The most acceptable theory till now is retrograde menstruation. There are many theories that explains or try to explain endometriosis, but the most successful and acceptable one is retrograde menstruation. Okay, this theory says that menstruation moves from the endometrial to the tubes and back to the pelvis, causing the endometrial tissue to out from the endometrium and endometriosis eventually. Okay, other theories like embolization and so on and so forth. Okay, this is the pathophysiology of endometriosis. How to evaluate endometriosis clinically? Okay, the clinical evaluation of endometriosis. We will start with history. First of all, history. Okay, what to ask about in history? Pelvic pain. The patient will come to you with pelvic pain and secondary dysmenorrhea. Okay, this dysmenorrhea or pain will eases during menses. Okay, will eases during menses. And by the way, the pain is not related to the extent of disease. So a patient may come to you with a severe pain and with low extent of the endometriosis and vice versa. Okay, so pelvic pain and secondary dysmenorrhea is the first symptom to come with. Okay, deep dyspareunia. Deep dyspareunia is very common and important symptom of endometriosis, and this dyspareunia is due to rigid cul-de-sac. Okay, the third symptom is subfertility. 30 to 40% of patients with endometriosis will be infertile. Okay, bowel habit changes with pain and bleeding, and this is due to adhesions that happen in the cul-de-sac. When endometriosis happens in the cul-de-sac, in the bleeding period of menstruation, this bleeding will cause adhesions and rigid bowels and abdominal pain, okay, pain and bleeding. So in the history you have to ask about pelvic pain and secondary dysmenorrhea, about deep dyspareunia, about subfertility and bowel habit changes, okay. Also endometriosis may come with no symptoms, may come with no symptoms, okay, may be asymptomatic. So to evaluate endometriosis, we start with history, and after history we'll move to physical examination, starting with vital signs, general look, etc., blah blah blah. The important thing here is abdominal and pelvic examination, okay, to see whether there is any pain, which is rare to have severe pain and acute abdomen in endometriosis in cases of rupture endometrioma, okay, case of rupture endometrioma. And we may feel a mass in rare cases when there is an endometrioma, large endometrioma in the ovaries. We will feel a mass. What is endometrioma? Do you know what is endometrioma? Endometrioma is a collection of blood from the bleeding from the endometrial tissue, okay. Endometrioma is chocolate cyst. It's called a chocolate cyst, okay. So we first of all, in abdominal and pelvic examination, we are looking for any masses from endometrial chocolate cyst or pain, okay. After abdominal and pelvic examination, we move to speculum examination. In speculum examination, we can see blue cervix, okay, and then we move to bimanual examination. In bimanual examination, we see fixed retrograde uterus, and this is due to cul-de-sac rigidity and adhesions that will make a fixed retrograde uterus, okay. So abdominal pelvic examination, then speculum examination to see the blue cervix, and then bimanual examination to see fixed retrograde uterus due to cul-de-sac rigidity and adhesions, okay. And eventually we are looking for adnexal masses, maybe due to ovarian endometrioma. We may have adnexal masses, okay. This is how we clinically evaluate endometriosis. Let's now move to the investigations of endometriosis, okay. We talked about definition, risk factors, pathophysiology, clinical evaluation, and now we are moving to investigations, okay. What investigations to do? Ultrasound can detect the presence of endometrioma, okay, or chocolate cyst, but the diagnostic test of endometriosis is laparoscopic examination, okay. MRI and ultrasound have an equal specificity and sensitivity to detect endometrioma, so ultrasound is to be chosen over MRI, okay. This is the investigations to do in endometriosis. How to manage endometriosis? What is the lines of management of endometriosis? First of all, we will start with conservative management. In mild cases with no symptoms, we will move to conservative management with painkillers, only painkillers, okay. Then medical treatment. Medical treatment targets to reduce the endometrial tissue as possible, okay, as possible as it could be. We in medical treatment, we will try to reach a state of pseudomenopause, okay, pseudomenopause with atrophied endometrial tissue. How can we do that? we can do that by inhibition of hypothalamic pituitary ovarian axis, inhibition of hypothalamic pituitary ovarian axis by using gonadotropin releasing hormone. Gonadotropin releasing hormone. This gonadotropin releasing hormone will cause endometrial atrophy and the status of pseudomenopause, and eventually this is a very good solution for endometriosis. An example of gonadotropin releasing hormone is Lepron. Okay, the second choice, or it is not a second choice by order, but another choice of treating endometriosis medically is pseudo-pregnancy drugs. We also want to reach a status of that is similar to pregnancy, where we have no menstruation. Okay, how can we do this? By using oral contraceptive pills or progesterone. Oral contraceptive pills or progesterone, which is very good to deal with the case. Progesterone like Depo-Provera and Provera. Okay, this is about medical management. So conservative management with painkillers, or medical management with pseudo-menopause drugs like gonadotropin releasing hormone like Lepron, or pseudo-pregnancy drugs like oral contraceptive pills or progesterone like Depo-Provera and Provera, to reach a case of no menstruation. This third choice is surgical choice of treatment of endometriosis. In mild and moderate cases we use surgical solution, and in severe cases we only use surgical solution before in vitro fertilization. What are the surgical options of treatment of endometriosis? The first one is laparoscopic ablation of chocolate cyst. By laser or by excision of the chocolate cyst. Okay. The second choice is total abdominal hysterectomy. And taking such a decision is should be when the patient has no desire for fertility. Okay, and in severe cases. So in the management of endometriosis, we have to take care about the age of the patient, the fertility state of the patient, and the severity of the case. So we only choose total abdominal hysterectomy in very severe cases and cases of that patient desires to have children. Okay, so what about the fertility in endometriosis? Infertility rates of endometriosis is about 30 to 40%. Okay, and again it is not related to extent of the disease, like the pain in the endometriosis is not related to extent of disease, and infertility also is not related. Okay, why do we have infertility in endometriosis? Because the anatomy of the tubes is disrupted in endometriosis due to the adhesions and the blood. Okay, and the most important thing is ovulatory and endocrine dysfunction. Okay, this is wrong, he should be Y. Ovulatory and endocrine dysfunction in endometriosis will decrease eggs reserve and eventually will lead to infertility and impair implantation. Inflammation is to be happened in endometriosis due to bleeding. Okay, and this inflammation will lead in some cases to impaired implantation and to infertility eventually. Okay, so how do we manage infertility? Most of cases we do not use medical treatment, because medical treatment is associated with a risk of teratology. Okay, we do surgeries in mild to moderate cases, and in severe cases only before in vitro fertilization. Thank you for listening. See you in the next video.